Mastering Depression, Rational Emotive Behavioral Therapy's powerful approach unveiled. Rational Emotive Behavior Therapy provides a comprehensive framework for understanding the causes of depression and offers effective interventions targeting cognitive, emotive, and behavioral aspects. This video discusses Rational Emotive Behavior Therapy's conceptualization of depression, detailed descriptions of its interventions across cognitive, emotive, and behavioral domains, and its effectiveness in treating depression. However, it is crucial to note that this video serves only as informative material and does not substitute professional advice or treatment. Depression is a multifaceted psychological condition characterized by persistent feelings of sadness, hopelessness, and a loss of interest in activities. Rational Emotive Behavior Therapy, developed by Albert Ellis in the 1950s, is a form of cognitive behavioral therapy that posits that our thoughts, emotions, and behaviors are interconnected, influencing our mental well-being. Rational Emotive Behavior Therapy conceptualizes depression largely as a result of irrational beliefs and inferences. Ellis proposed that individuals become depressed when they infer that a particular event or series of events or situations constitutes a major personal loss. The individual then holds dysfunctional or irrational beliefs about themselves, others, and the world. Common irrational beliefs include demandingness, e.g., I should have not experienced that major loss, awfulizing, e.g., experiencing that loss is horrible, and frustration tolerance, e.g., I can't stand it that I have experienced this huge loss. These irrational beliefs contribute to distorted perceptions, unhelpful negative emotions, and maladaptive behaviors, fostering and perpetuating depressive symptoms. Let's dig more deeply into the types of distorted perceptions and maladaptive behaviors associated with depression. Depression often leads individuals to perceive themselves, their environment, and their future through distorted lenses, fostering negative beliefs and perceptions. The following are two examples of distorted perceptions commonly present in depression. Global negative self-rating is at the heart of most expressions of depression. For instance, a person experiencing depression might blame themselves entirely for a relationship ending, despite multiple contributing factors. Another type of distorted perception commonly seen in depression is awfulizing. Individuals with depression tend to magnify negative events, expecting the worst outcomes. They might spend an inordinate amount of time awfulizing about a minor setback, believing it will lead to a series of catastrophic events, reinforcing their depressive feelings. In addition to distorted perceptions, in depression one also sees maladaptive behaviors. Depression often manifests through a range of behaviors that perpetuate and exacerbate depressive symptoms. Two examples of maladaptive behaviors follows. Social withdrawal is frequently present in depression. Individuals with depression may isolate themselves, avoiding social interactions and activities they once enjoyed, which further reinforces feelings of loneliness and sadness. In addition to social withdrawal, individuals experiencing depression also frequently engage in avoidance. They might actively avoid situations that trigger discomfort or anxiety, leading to a limited and constricted lifestyle, hindering personal growth and reinforcing depressive symptoms. So how does Rational Emotive Behavior Therapy go about treating depression? Rational Emotive Behavior Therapy has three categories of interventions to treat dysfunctional emotions. Those interventions are cognitive, emotive, and behavioral interventions. Cognitive interventions in the therapy focus on identifying and challenging irrational beliefs through cognitive restructuring. Therapists assist individuals in recognizing and disputing their irrational thoughts by encouraging them to examine evidence supporting or refuting these beliefs, as well as the ways in which holding the dysfunctional beliefs tend to sabotage attaining desired life goals, both short-term and long-term life goals. Through the ABCDE model, activating event, belief, consequence, dispute, effect, individuals learn to replace irrational beliefs with rational, adaptive thoughts. For instance, changing I must be perfect to be worthy to I can accept myself even with imperfections fosters healthier beliefs and reduces depressive symptoms. Emotive interventions in the therapy involve addressing the emotional responses associated with irrational beliefs. Techniques such as emotive imagery, where individuals vividly imagine challenging situations and work through associated emotions, help to desensitize and reframe emotional reactions. Additionally, using humor where appropriate, rational emotive imagery, and shame-attacking exercises assists individuals in developing a more rational and adaptive emotional repertoire, reducing the intensity of depressive feelings. Behavioral interventions aim to modify maladaptive behaviors associated with depression. This includes activity scheduling, where individuals engage in pleasurable and fulfilling activities, even when not motivated, to counteract feelings of lethargy and disinterest. Homework assignments, such as behavioral experiments, assist in testing and challenging irrational beliefs in real-life situations, promoting behavioral change and reducing depressive symptoms. Research consistently demonstrates the effectiveness of rational emotive behavior therapy in treating depression. Studies have shown significant improvements in depressive symptoms, increased cognitive flexibility, and enhanced emotional regulation among individuals undergoing the therapy's interventions. Meta-analyses and systematic reviews support the efficacy of the therapy model, indicating its potential as an effective treatment modality for depression. Let's consider a fictional case of depression and begin with an intake summary. Mary S. is a 32-year-old who identifies as female. Mary sought therapy due to persistent and debilitating symptoms affecting various domains of her life. Over the past year, she reported pervasive feelings of sadness, loss of interest in activities she once enjoyed, significant weight loss, insomnia, fatigue, feelings of worthlessness, and recurrent thoughts of death. Mary's symptoms of depression manifested gradually over the past year. Initially, she experienced a loss of motivation and pleasure in activities she previously found enjoyable, such as socializing with friends, engaging in hobbies, and pursuing career goals. These changes were accompanied by disrupted sleep patterns, loss of appetite leading to significant weight loss, and persistent fatigue despite adequate rest. Mary's depressive symptoms intensified over time, impacting her work performance and interpersonal relationships. As a marketing professional, she struggled to meet deadlines, experienced difficulties concentrating, and withdrew from collaborating with colleagues. Her decreased productivity and disengagement at work led to performance reviews reflecting a decline in her overall effectiveness. In her personal life, Mary's symptoms severely hindered her social interactions. She withdrew from social gatherings, distancing herself from friends and family members. Her isolation exacerbated feelings of worthlessness and contributed to recurrent thoughts of death and hopelessness. Mary's depressive symptoms significantly impacted her career trajectory. She was unable to maintain her previous level of productivity and engagement at work, leading to setbacks in achieving professional goals and jeopardizing her job stability. Her withdrawal from social activities and disengagement from relationships affected her social support network, amplifying her feelings of loneliness and isolation. This further exacerbated her depressive symptoms, creating a cycle of withdrawal and negative emotions. Mary's disrupted sleep patterns, loss of appetite, and persistent fatigue resulted in substantial weight loss and overall physical deterioration, contributing to a decline in her overall well-being. Additional case specifics include a collection of Mary's dysfunctional or irrational beliefs of demandingness, I must be perfect to be worthy, awfulizing, it's terrible that I've failed, and frustration tolerance, I can't bear the thought of not succeeding. Lead her to engage in maladaptive behaviors such as social withdrawal and avoidance. These beliefs perpetuate her depression by distorting her perceptions of herself and the world, fostering self-condemnation, and amplifying the fear of failure. Let's consider a DSM-5 diagnosis. Mary meets the criteria for major depressive disorder based on the DSM-5 diagnostic criteria, which include depressed mood most of the day, nearly every day, as indicated by subjective report or observation by others. Markedly diminished interest or pleasure in all, or almost all, activities most of the day, nearly every day. Significant weight loss when not dieting or weight gain, or decrease or increase in appetite nearly every day. Insomnia or hypersomnia nearly every day. Fatigue or loss of energy nearly every day. Feelings of worthlessness or excessive or inappropriate guilt. Recurrent thoughts of death, recurrent suicidal ideation without a specific plan, or a suicide attempt or a specific plan for committing suicide. Based on the client's presentation and the symptoms constituting the DSM-5 diagnosis, the therapist developed a rational emotive behavior therapy-based treatment plan that included cognitive, emotive, and behavioral interventions along with progress monitoring. The cognitive interventions included identifying Mary's irrational beliefs, such as demandingness, I must be perfect to be worthy, awfulizing, it's terrible that I've failed, and low frustration tolerance, I can't bear the thought of not succeeding, that contribute to her depressive symptoms. using the ABCDE model to challenge and replace these beliefs with more adaptive thoughts. Emotive interventions included emotive imagery and rational emotive imagery exercises to confront and reframe emotional responses tied to her irrational beliefs, incorporating humor and shame-attacking exercises to develop a more rational and adaptive emotional repertoire. Behavioral interventions included implementing activity scheduling to encourage engagement in pleasurable activities, despite lacking motivation, assigning behavioral experiments to challenge her irrational beliefs in real-life situations, promoting behavioral changes, and reducing depressive symptoms. Regular assessments using standardized measures like the Beck Depression Inventory were used, BDI, to monitor Mary's progress. Consistent discussions and reflections with the client on changes in thoughts, emotions, and behaviors to inform adjustments to her treatment plan were a regular part of monitoring progress in therapy. Disclaimer: the case presented here is fictional and for illustrative purposes only. It does not constitute professional advice or diagnosis. Individuals seeking mental health treatment should consult qualified mental health professionals for appropriate evaluation and treatment. This video is purely informational and does not provide legal, medical, or psychological advice or treatment. Individuals seeking help for depression or any mental health concerns should consult qualified mental health professionals for appropriate evaluation and treatment.